we will be learning today the basics, only the basics, so that if our basics are strong, our foundation is going to be very strong. Fine. So I am going to start with the anatomy first. When we talk about the knee joint is, what is knee joint? It's an articulation, synovial articulation between the lower end of your femur and the tibia. And then the articulation between your femur and the patella. Means the fibula has no role in knee joint. Fibula is not a part of the knee joint. So knee joint is between femur and tibia and between femur and patella. So synovial articulation between these bones. Second thing, just have a look at the articular surface, the lower end of your femur. And this is the articular surface, which looks like this, and we call it as trochlea. If you look at the femur from the back, now you're able to see that the femoral condyles, they are rounded. And in between these two condyles, you have a gap, and this gap, we call it as intercondylar groove. Coming to the tibia, this is the tibial tuberosity, because when I'll be showing you the sonoanatomy, I will be talking about this. So you should be aware of this very important thing. So this is your tibial tuberosity, and this is, we call it as tibial plateaus. This is the medial side, the lateral. Medial is bigger as, oh, sorry, I'm really sorry for that. So medial side is bigger as compared to the lateral. So what we have seen is the tibial plateaus, they are flat, and the femoral condyles, they are rounded. So in order to increase the stability, because one surface is round, one surface is flat, so the joint will be an unstable joint. So in order to increase the stability of joint, what all we have? Okay, before going into that, let us just have a look to this patella also. This is patella. Remember, its base is this one. Means on the top, you have the base, and the lower portion is the apex. This and this is very important, because the quadriceps tendon will be attaching here, and your patellar tendon will be starting from there. And if you are looking at the posterior aspect of your patella, you have a groove, and this groove will be dividing this, the posterior aspect. You have a medial facet and the lateral facet. So when you're looking at why this apex is very important, because when we are looking at the patellar tendon doesn't attach to this area. It attaches to this and this area also. So if you are scanning the patellar tendon, which I'll be showing you, so we need to slide our probe from the midline little laterally. Why? Because of this structure of the apex of the patella. Then I have told you about that this joint, because one surface is convex, the other one is flat. So this joint is an unstable joint. Now to increase the stability, what all we have? This is medial meniscus. This is lateral meniscus. What are they? They are the fibrocartilaginous structure. Like I have shown you when we were talking about the shoulder joint, we have the labrum there. So here we have the medial meniscus. And one thing which you should know about the medial meniscus, as you can see, this is almost between the two articular surfaces. So if you have any meniscus injury, because we will be able to see only this much portion of your medial meniscus. So if you have any problem with your medial meniscus, USG is not the diagnostic modality of choice. MRI should be the diagnostic modality of choice. Second thing, you have anterior cruciate ligament and the posterior cruciate ligament. Just remember them, that they will be catching hold of the tibia and the femur. So if it is ACL, that is going to prevent the anterior translation of the tibia. And if it is PCL, that is going to prevent the posterior translation of the tibia. If this would not have been there, what would have happened? When you are going to flex your knee, everything will be coming out. And when you are trying to extend, everything will go back. So in order to prevent the anterior and the posterior translation, we have ACL and PCL. So imagine we are going from the interior to the outer aspect of the knee. So what we have seen in the interior most, we have seen the meniscus, then we have seen the cruciate ligaments. Now we are coming to the superficial surface from the deeper surface. So when you are coming from the deeper to the superficial surface, you have this synovial membrane. On the top of the synovial membrane, you have your capsule. Then This is your medial and this is your lateral patellofemoral ligament. So patellofemoral ligament, as I told you in my basic class also, when we say ligament, it is connecting one bone to another bone. And that is going to increase the stability of these two bones. So when I say medial and the lateral patellofemoral ligament, so patellofemoral from the patella to the femur. Medial, it's on the medial side. Lateral, it is on the lateral side. Now, if you see this MPR, sorry, this is, it should be LPR because this is on the lateral side, you have the fibula there. So MPR and LPR, these are what? These are retinaculum. Retinaculum, medial and lateral, patellar retinaculum. These retinaculum are the extension, fibrous extension of the vastus muscles which are located above. I'll be showing you the muscles, that time you will be able to understand it in a better manner. This is how, why is it important? Because if you remove the patellar retinaculum, you have your capsule, then is your synovial membrane, and then is your joint. So if you are not able to go inside the joint, from the suprapatellar approach, you can inject inside the joint through this approach. So that's why knowing this retinaculums are very, very important for us. From that, now let's move on to the medial collateral ligament. Medial collateral ligament is the one which is present on the medial side. And this is the one which is connecting your femur condyle to the tibia. This is how it looks like. Then coming to the lateral side, you have the lateral collateral ligament. Remember one thing, very, very important. Medial collateral ligament is from femur to tibia. But when we say lateral collateral ligament, it is not from femur to tibia. It is from femur to your fibula. That's why when we'll be putting the probe, our probe should be from femur to fibula. It should not be from femur to tibia. From femur to tibia, we won't be able to see this ligament. And that's the importance of knowing where it is originating and where it is inserting. Then I'll be just talking about the bursas. These bursas which are present on the anterior aspect, they are very, very important. Some books says it as suprapatellar bursa, but believe me, it's not a bursa, it's a rhesus. Why we call it rhesus? Because that is a synovial extension, as you can see in this picture. This is a synovial extension, and this is the bursa. This is the rhesus where we will be injecting, are injected if we want to inject anything. You know, you want to go for a dextrose, you want to go for a local with steroid, you want to go for your PRP. So this is the place where we will be injecting. And the other one is through the retinaculum, which I'll be showing you today. And then you have prepatellar bursa. Always remember it with the name. Suprapatellar means there is something which is on the top of your patella. When I say prepatellar, means this is something which is in front of the patella. Then you have infrapatellar, superficial, and the deep bursas. Here you have the ligament, the patellar ligament. This is the patellar ligament which you are able to see in your white thing. So if one which is in front of this patellar retinaculum, we call it as superficial, and which is and the deep, we call it as deep infrapatellar bursa. Inflammation of this bursa is very, very important. This we call it as housemaid knee bursa, and this is your clergyman bursitis. If you have the inflammation here, we call it as clergyman, and if it is here, that is housemaid, because they'll be kneeling down and you will be having the constant rubbing action of this bursa. It will get enlarged, and that condition we call it as housemaid bursa. Now there are various other bursas if you want to remember. This is a little towards the higher version of the knee joint. You have another iliotibial bursa that will be lying beneath the iliotibial band. And if you have the inflammation of this bursa, we call it as iliotibial band syndrome. And when you have the inflammation of your iliotibial band, we call it as distal iliotibial band tendinopathy. This you should remember, okay? Because these are two different identities and we should not be getting confused. And then other bursas you have over the, just beneath the attachment of medial and lateral gastron. So if you want to remember it, it's fine. But for a basic course participants, you should never miss on this bursas. They are very, very important and very easily accessible with your ultrasound. Then coming to the muscles, when I say quadriceps tendon, quadri means 4. So there should be 4 muscles. They are combining to form a tendon. So we call it as quadriceps tendon. Now, what are those 4 muscles? Very easy to remember, 3 vastus and 1 rectus. So 3 vastus, you have the vastus lateralis, you have the vastus medialis, and then you have the vastus intermedius. So and on the top of this intermedius, you have the rectus femoris. So 3 vastus, again, I'm repeating, medialis, intermedius, and then lateralis. And on the top of intermedius, you have the rectus femoris. So this rectus, these 4 muscles, they combine to form a tendon, and that tendon, we call it as quadriceps tendon, and which will be inserting itself on the superior pole of the patella, which we have learned just now. And then some say that some of the fibers of this rectus femoris, they continue down and get attached to the they attach to this tibial tuberosity, which I have shown you. So that is the tibial tuberosity. So that's why they call it as patellar tendon. But there is one school of thought that says it's not a tendon because it is from a bone to a bone, and from a bone to a bone, we call it as ligament and not a tendon. So it depends on you which school of thoughts you want to follow, but both they are equally important. If you call them, they are not wrong. So if you find it as tendon or you find it as ligament, do not get confused. It is one and the same thing. So you have 2 tendons. One is your quadriceps tendon, which we'll be looking from the anterior aspect, and the other one is your patellar tendon. Coming to the medial side, you have 3 muscles, that is sartorius, then you have your gracilis and semimembranosus. How can you remember is, you have 1 muscle from the anterior compartment. Anterior compartment muscle is your sartorius. Then you have 1 muscle from the medial compartment, that is your gracilis, and then you have 1 muscle from your posterior compartment, that is semimembranosus, that is a part of the hamstring muscle. These muscles, where they are attaching, as you can see on the proximal end of your tibia, you have a bursa which is lying beneath this muscle, and that is known as pes anserine bursa. And if there is an enlargement of that bursa, we call it as pes anserine bursitis. These are the muscles which are present on the posterior aspect. You have semimembranosus, semitendinosus, and the biceps muscle, the medial and lateral gastroc and plantaris. This portion I will be showing you when I'll be taking your lower limb nerve class, because that time I will be demonstrating you the popliteal sciatic and of course the tibial. So today we are skipping this, and I will be covering it when I'm taking your lower limb class. Now, on the lateral side, we have learned there is iliotibial band, and this iliotibial band attaches itself on the Gerdy's tubercle. What is Gerdy's tubercle? Gerdy's tubercle is an elevation which is present on the anterior aspect of the lateral plateau of the tibia. So, because this is present on the lateral side, this you can easily remember it. It is present on the lateral side. That's why its attachment should be on the lateral plateau. Lateral plateau, you have some bony projections on the anterior aspect, and that is Gerdy's tubercle. And what is iliotibial band? That is a condensation of the deep fascia of your leg. So you have a bursa which is lying beneath that. Until unless it is enlarged, you will not be able to see it. So this tendon, where it is getting attached, if you are able to see the tendinopathy features over there, we call it as distal iliotibial band tendinopathy. And when you are able to see the enlargement of the bursa, we call it as iliotibial band syndrome, and that is also known as runner's knee. And you will be able to see it in mostly in those people who just run, because there'll be a flexion, extension. So you have the chronic wear and tear of this bursa, and that results in the accumulation of fluid and this pain on the lateral side. Then remember 3 fats. One is your suprapatellar. Then you have prefemoral. Always remember it with the name. Suprapatellar means it should be above the patella. Prefemoral means it should be in front of the femur. Infrapatellar means it should be beneath the tendon, patellar tendon. So these are the 3 fat pads which you should be remembering. And that's all about the anatomy. So let me summarize once again, and then I'll be going to the history taking. Knee joint is a synovial articulation between your femur tibia and your femur and patella. Then if we are going from the deeper to the superficial aspect, you have your meniscus. These are the fibrocartilaginous structure. Any fibrocartilaginous structure in ultrasound is going to look hyperechoic. So meniscus, then you have two ligaments, ACL and PCL. ACL and PCL, they will be preventing the anterior and the posterior translation of your tibia. You come out, you have your synovial membrane. Again, you come out, you have your capsule. And then you have your medial and the lateral patellofemoral ligament. And on the top, you have your retinaculums. On the front, you have quadriceps tendon, patellar tendon, and bursas. On the medial side, you have the pes anserine tendons. And on the lateral side, you have your iliotibial band. And at the back, you have your hamstring muscles. Easy? So that was all about the anatomy. Coming to the history. So history always, like I have told you when I was taking your shoulder also, if you have a problem with your joints, so it could be a degenerative and an inflammatory pathology of the joint. Broadly, if you're classifying it, degenerative, the patient is going to have pain at rest. And this pain, there will be a morning stiffness, and this morning stiffness will be less than 30 minutes. And this degenerative, the patient is going to be older individual. When we are talking about the inflammatory component, the patient is going to be young. He will be having pain. The degenerative, he will be, the pain will be getting worse when he is taking walking also. And this inflammatory component, when he is doing some work, the pain will become better, but at rest, the pain will be more if there is an inflammatory pathology. But if there is a degenerative pathology, the pain will be better when that person is taking rest. So broadly, we can classify it like that. If there is any arthropathy of the joint, you're going to have pain, you're going to have stiffness, you're going to have decreased range of motion. When you are going to talk about the tendons, we have seen two tendons. So we are going to have quadriceps tendinopathy or the patellar tendinopathy. Tendinopathy, again, the patient is going to have pain, and then, sometimes it could be the weakness, relative weakness, not the absolute weakness with which the patient will come to you. Ligaments will always present with instability. You can have a referred pain to the knee from the hip or from the spine. And bursas, yes, if they get enlarged, you can have bursal inflammation. So that can also be a cause of pain. So broadly, we have learned these structures, and any of the structures can be a pain generator. Red flags are the same, what I have already covered during my shoulder class, and I think that would have been covered by Devjyoti boss and Chinmay boss also during the elbow class. So they remains the same. And then this pain history, I hope all of you now must be well versed, because with this mnemonic, Olacar nitride, O was for the onset, L for the location, C for the character, A for the aggravating, R for the relieving, N is obviously night pain, and R is for the radiation. So this mnemonic, let's see how it holds true for the knee joint. So when we say onset, acute onset, if the patient comes to you, usually acute onset, hardly the patient will come to us, but still you should have this idea. If the patient says, like, I was just quickly walking and suddenly somebody called me, so I just stopped all of a sudden and I just turned sharply. So that time you can have an injury of your ACL. ACL injury, immediate, you will be having the swelling and accumulation of the blood inside. So immediate swelling of the knee joint will be there. But if the patient says, I was just playing and suddenly it got twisted, so that time you can have your meniscus injury and the ligaments injury. The collection of the fluid or the knee swelling will take some time, 24 to 36 hours. So maybe the patient will come to you after 2 or 3 days. And you can have the injury of your ligaments, both the medial and the lateral side. So this is briefly about the history, how the patient will present to you if the onset of the pain is acute. Most important for us is this chronic, because most of the time, the patients with the chronic pain are the ones they will be visiting us. So chronic, yes, you can have the arthropathy, you can have the degenerative and the inflammatory, which I have already discussed. You can have the tendinopathy of your quadriceps, and you can have the tendinopathy of the patellar tendon. You can have the bursal enlargement, the iliotibial band syndrome. So all these patients you will be seeing in your day-to-day practice if you are having a pain OPD. Location of the pain. Now, always location is very easy. You just think of what all structures are present on that aspect. So only those structures can be your pain generator most of the times. So just example, we have seen this anterior aspect. We have seen the quadriceps tendon. We have seen the bursas. We have seen the patellar tendon. So if the patient is complaining of anterior knee joint pain, think of all these conditions. If the patient is complaining of the medial side knee joint pain, think what all structures are present there. So we have the collateral ligament, we have the medial joint line, we have the medial meniscus, and of course, a little down from the joint line, we have the pes inserting bursa. So if there is an inflammation of that, yes, the patient can complain of medial side pain. Coming to the lateral side, again, the same thing, but in addition, that is your iliotibial band. So location is very easy. Think of just the structure. Close your eyes, think what all structures are present, and then it becomes very easy. Character of the pain. When we say sharp shooting pain, think of all the radiculopathies. Though the entrapment neuropathies are very, very, I should say, not very common in knee, except the Cephalus one, that too itself is very rare. So think of radiculopathies when the patient is complaining of a pain of that kind. Dull aching will always be from the joint pathologies or from the tendinopathies. Then ask for the aggravating factor, like a patient who is like having an OA comes to you, what he will say. Typically this history, she or he will give that when I'm sitting on the floor, when I'm trying to get up from the floor, I need to use my hands. When I'm walking, sometimes I feel some sound is coming from my joint. Climbing up the stairs is very difficult for me. So always ask for all these structures. What exactly is aggravating the pain of that patient? Do ask about the history of like aggravating factors, and then the relieving factors, it holds true for every joint. Night pain, yes, they are more common in inflammatory pathologies, and radiation, if it is dermatomal, that could be because of the disc prolapse, lumbar disc prolapse. Non-dermatomal, it could be because of any hip pathology coming to your knee. Now, this was the mnemonic, again, I asked you, and this, believe me, it holds true for every joint. What was W? WIP section. This is how we remembered the mnemonic when I was taking your shoulder class. The same you would have learned during your elbow classes. So this is weakness. Weakness can be relative and absolute. Relative, I have already discussed that if I'm having pain, maybe I don't feel like moving my joint. So that is relative weakness. Now, absolute, don't have pain, but I'm not moving it at all. I'm not able to move it. So active itself is 0. So that 0 is like absolute weakness. Then I was for instability. Instability will always be with some problem with your ligaments, because they are the one, they are holding your joint. So if there is some problem with the ligament, you have the patient, how the patient will come say to you that whenever I'm walking, I feel my knee is giving away. So that is instability. And you do see this instability if there is a patellar subluxation. Then P was for paresthesia. Paresthesia is usually you will get when there is an entrapment of the nerve. SE was your stiffness. Stiffness, you can get it in both the inflammatory as well as the degenerative pathology, but the duration of the stiffness, it will be more than 30 minutes if there is an inflammatory component, and it will be less than 30 minutes if it's a degenerative component. Degenerative, usually they'll say 5 to 10 minutes. That is how they will be presenting with the history. And C was for clicking sound. So here you will be able to see the crepitus, and that crepitus will be more if there is an inflammation of the joint. Locking, this is very important in knee. If the patient says, I'm walking and suddenly I feel my knee has got locked, think of meniscus pathology. Very typical history, and especially in knee joint. So that was all about the history. These are the other histories, the same way we have taken. So you need to take it. And then we'll be coming to the inspection, and from the palpation, I will be demonstrating it in the volunteer. So just have a idea that in inspection, you need to inspect, ask the patient, you can have some shots, you can keep it with yourself, ask the patient to wear those shorts so that it will be very easy for you to examine the knee properly. So you need to look at the knee from the front. See here in this, my volunteer, I have marked you. This rounded thing is your patella. On the top, you're going to have your quadriceps. Here, your patellar tendon. This is your tibial tuberosity, and this was your joint line. So examine your patient from the front, from the side, from the back. Look for any, this is the same inspection we have been learning from the MBBS days. You look for any surgical scars, look for any swelling. Now, what is typical in knee is you are able to see this hollow. I'll be showing you, but just have a look that these hollow, if there is any effusion, this is going to get swollen up. These hollow things which you are able to see on the sides of the patella. Look for any abnormal posture, whether the patient is just trying to stand with the knee bowed or knee towards the midline. Muscle wasting is very important, and here you will be looking at the vastus medialis, because rest everything is not that much visible as compared to the vastus medialis. So always look for any muscle. If you want to look for, suppose there is any atrophy of the muscle, you want to look for, like if there is a femoral nerve entrapment, you're going to have the atrophy of your quadriceps. So that time you should be looking at the medial side. Look for any color changes over the skin, rash, or any cutaneous lesions. So that was all about the inspection. And now I'll be showing you the palpation. So one thing again from the history, let me revise once again for you. That in the history, when we are seeing, like if a patient is complaining of pain, decreased range of motion, stiffness, think of a joint pathology. If the patient is complaining of pain with some kind of instability, giving away of the knee, think of a ligament pathology. Patient presenting with, please mute yourself if you don't have any questions to ask, because that really distracts the class. So if the patient gives you a history of locking, think of a meniscus pathology. So this briefly, you can just club the symptoms and you can just think of a clinical diagnosis, and which you will be confirming with your examination and finally with your ultrasound. So I'll be just demonstrating you the palpation. Just give me 2 minutes time. Sure. On it. Bus. So are you able to see his knees? Anybody can unmute.
Yes, madam.
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Fine?
Yes, ma'am.
Yes, ma'am. So what we are going to do first is, okay, let me focus it more for you. Or can I just bring it closer? But then I have to demonstrate you. So that time I'll be just moving it away. This is what? This is the patella. What-
Not seen in full screen, madam.
I have pinned my video. Still? What view are you seeing? Speaker view?
Ma'am, full screen is visible.
That's what I'm
Full
saying.
screen is visible, ma'am.
Visible, thank you so much, whosoever has helped me. I'm very thankful. Can you increase the size of screen? More than that, I cannot increase. This is the full screen. Okay, so let me start with the
So double click on this view, on this window, and it will be larger. Just double click on this window where Dr. Kanchan is demonstrating.
Sir, are you saying it to me?
No, I am asking the participants. Just
Oh,
double
okay,
click,
sir. Okay, sir. Thank you.
on the window, and then it will be larger.
See, this is for all of you. My technical knowledge is very bad. Okay, so let's start with the palpation. So first, what you can do is just have an idea that this is your patella. Now, this is the superior aspect. So this becomes the superior pole. And when you are trying to feel it, this becomes the apex, which we have learned. Now, what I'm going to do is I'll be flexing his knee. Okay, let me show you again. So when we have flexed, now this is the whole patella. So what you need to do is, if you start palpating from here, so if you are putting your pressure with your thumb, and if the patient is complaining of pain, this is suggestive of quadriceps tendinopathy, because the quadriceps, the tendon will come and it will be attaching itself on the superior pole of the patella. Now keep palpating, and if the patient is complaining of pain here, so this is a bursa which is lying in front of the patella. So that is your prepatellar bursitis. If there is a bursa, you will be able to see the inflammation, as well as if you're going to press it, it's going to be tender. Now from there, you come down and then you palpate here, just beneath this. So that is the apex of the patella. So if you have patellar tendinopathy, that is also known as jumper's knee. So if you have patellar tendinopathy, the patient is going to complain of pain here. Now come down, and if you're coming down, if just beneath that, you have put your finger there, and if the patient is complaining of pain over there, so that is suggestive of any superficial infrapatellar bursa. So this one was housemaid, this one is clergyman's. Fine, and then you will be flexing, and what you should do, you palpate your tibial tuberosity. There is one condition known as Osgood-Schalter disease there, where you have the benign inflammation of the tibial tuberosity, but you don't see it in adults. Mostly it is seen in adolescents. So those patients will not come to you, but still just have an knowledge about it. We don't have to do anything in that. So this is your tibial tuberosity. Now from the tibial tuberosity, you keep on, I will show you from here so that it is nicely visible for you. So from your tibial tuberosity, you keep on moving. So once you are moving, you just flex. So you will be able to see a gap there. So that is your joint line. So if the joint line tenderness is there on the lateral side, that is suggestive of either a lateral meniscus pathology or a lateral collateral ligament pathology. So from the tibial tuberosity, if I am moving down, if I am having pain here, so that is suggestive of iliotibial band tendinopathy. And if I am moving up, and if the patient is complaining of pain somewhere here, on the top, so that could be suggestive of your iliotibial bursal inflammation, which is also known as iliotibial band syndrome. Now this was all, and the same thing you should be doing for the medial side. And if the medial joint line is also tendon, it could be because of a joint pathology, meniscus, your ligament, right? And for the pes inserine, I will be showing you in this knee, because that is the medial side. So this patient will be complaining of pain somewhere here on the medial side. So that is of the pes inserine bursa. So this is what roughly you will be just palpating and you will be seeing. Now today, what we will be doing, we will be learning only one test for each joint. We should not be, there are ample amount of tests which are available, but what I'm telling you, if you will do all these tests, that is more than sufficient for you as a beginner in pain medicine. And as you increase your knowledge further, yes, you can keep on adding many tests, but sometimes if you see it practically, believe me, it's very difficult to perform all the tests. If you do two tests for one thing, then what will happen? That is going to take lots and lots of time in your OPD. And the patient will say, this doctor is, testing. I think she or he doesn't know anything. So just learn one test. So again, we will go from the inside and we'll go to the outside. But before that, the range of motion. Again, I'll be showing you in this knee. So range of motion. Okay, let me show you like that. This, I need to lift it up. Okay. Is it visible? So this is the flexion. What is flexion? You will be asking the patient, this is the heel of the patient, to touch the buttocks. So that is the flexion. And from there, if you are, again, bringing it back like this, this is the extension. Now, sometimes what will happen, this whole straight line will not be there, but it will be like this. And when you will hold it, and if you're able to do a full flexion, So that is suggestive of quadriceps tendinopathy, and this test is known as extensor lag sign. Fine. So first you test for the flexion, then extension, and just see whether this line is full or not. If this line is just a straight line, you're very happy. But if it is not a straight line, it is something like this. And if you're asking the patient to say, no, I'm not able to do so. And if you are able to do so, this is extensor lag sign. So that is the range of motion. Second, we have tested for the range of motion, flexion, extension, and we have looked for the quadriceps tendinopathy. Now, patellofemoral arthritis. What you need to do is you press here on the base of the patella. You press like this. Fine. And let me show you. You keep your one hand here and then ask the patient to press on your hand. When the patient will be doing so, he will be contracting the quadriceps. And if you are going to have the patellofemoral arthritis, you are going to feel, the patient is going to feel the pain. This area will be tender and you will be sometimes able to even feel the crepitus. So let me just do it for you. Press karo, mere haath pe. See. Fine. So patellofemoral arthritis also we have tested. Now we will be testing the ACL. ACL, I usually don't go for an anterior draw test because sitting on patients, foot, patient sometimes is not very comfortable. So I will be telling you two tests, and these two tests has got a very good specificity and sensitivity. What you need to do is this knee. This should be in 30 degree of flexion. Supposedly it's a very bumpy, plumpy knee, and if you're not able to do so, what you can do is have these kind of roll so that you can just put it there, okay, so that hamstrings are relaxed. And now hold your tibia fully from the back like this, and then translate it anteriorly. If you are able to see an excessive translation, that is suggestive of ACL problem. Now, other than that, suppose that also you are not able to do so. So what you can do, you put your one, you make a fist, keep it here, and you need to look for this movement. If there is any pathology of the ACL, see, this movement will not be there. See, when I'm pressing, I'm just holding the femur and I'm just trying to compress it. This movement should be there. This jerk should be there like this. It is moving now. That will not be there if it's an ACL pathology. Coming to the PCL, you ask the patient to just flex the knee to 90 degree. Now this becomes the axis of the femur and this is the tibia. So we are approximately at 90 degree. What you need to do, okay, let me, for PCL, there is a test known as posterior lag sign. What will happen? You ask the patient to do like this. You flex it and ask the patient to keep it like that. If there is a PCL problem, okay, so what will happen? This thing will sag. If this thing will sag, what you need to do is you hold here and ask the patient to contract the quadriceps. Now patient doesn't know how to contract the quadriceps. So now we have already told him like to press upon our hand. The same thing, you just tell him that you need to press upon my hand, which is here. So that is another way of just telling to the patient. So when the patient will be contracting the quadriceps, the tibia, which has gone down, will pump up. Okay, so that is the active quadriceps test, and that is for your PCL. So ACL, Lilly's test, which I have shown you like that, and Lockman's test. For PCL, that is the posterior lag sign, and quadriceps active test. Now for the ligaments, what you need to do, this is same for all the ligaments in our body. If it is the medial side, you need to put your hand over here, and then you need to give a valgus stress. You need to pressurize your medial. You will be giving the pressure from this side with this hand, keep it here, and then bring your, the lower end. You will be just holding here, and you have to pull it to that side. If there is a problem with your ligament, what will happen? There will be an increase in the joint line, and you will be able to see an excessive motion of that, that side. And if you have any problem, every time what you can do is always compare with the normal side. So for medial, that is the valgus test. For lateral, okay, lateral I'll show you here because that lateral side is visible. So lateral, I will be applying force from this side, and this I will be bringing towards this side. So this is varus, I'm bringing it towards the midline. If I'm taking it away from the midline, that is the valgus. So now we have tested for the ACL, we have tested for the quadriceps tendon, we have tested for the collateral ligaments. Now only one thing which is left is your meniscus. For testing the meniscus again, let me show you like that. You have to flex. Let me lift it for you. You have to flex the knee. We have flexed the knee. Now, for this tibia, if you want to test for the medial meniscus, we have to do the external rotation. So this, I am holding it. I am keeping these fingers on the medial joint line. I am doing an external rotation. Fine, this is flexed. Now it will be visible. So I have flexed it. Okay, let me show you like that. So I have flexed it. I put my hand over the joint line, externally rotated, and then you have to just extend it by applying a valgus stress. Now, what will happen if supposedly you have flexed it, you have done the external rotation, and when you are trying to extend it, what you will feel? The patient, you will be able to feel a clicking sound. Patient will be having pain. And if supposedly the patient is having right now here itself, think of a posterior horn. If it is here mid-range, think of a medial. And if it is fully, then think of the anterior horn of your meniscus pathology. So this is what for the medial meniscus. And for the lateral, same thing, and internally rotated, and same way you need to extend it. And the one thing which you need to keep in your mind is that if you are testing for the medial meniscus, this finger should be on the medial joint line. If you are testing for the lateral, it should be on the lateral joint line. So that was all about the examination part. And if you have any question, you can ask me, or else I will be just starting the sonoanatomy now. Anything anybody wants to ask? No? Okay.
Hello, ma'am. Hello, ma'am. Ma'am, can you just regarding the distal ITB tendinopathy, the location of both?
Oh, yes. I have forgotten to tell you the test also. Thank you for reminding me. Okay, showing you. Coronary ligaments. I don't know. I think sir can tell you. I don't know the test for the coronary ligaments. Okay, so let's see for the iliotibial band. Now, I will be showing you in the ultrasound how exactly the band will look like. So this is the iliotibial band on this side here. So this is the band which is coming and getting attached here. So if you have a pain here on this area, so that will be suggestive of distal tibial iliotibial tendinopathy. But the patient doesn't have a pain here. Patient says, I have a pain in this area. So what you have to do, flex it, keep your hand over there and try to extend it. When you will be trying to extend that, you will be able to feel the patient, it will be very painful for the patient, and you will be able to feel the crepitus over there. So that is more suggestive of your iliotibial band syndrome.
Ma'am, regarding the tendinopathy point, where is that exactly? Is it over the joint line?
No. See, I'll tell you once again. I'll bring this very near so that now it is super duper visible to you. Who asked me this? Can I know your name?
Ma'am, is Dr. Kostov.
Okay, now see. This is your tibial tuberosity?
Yes.
This is the lateral side. Now I'm showing. Fine, here it is. So this is your tibial tuberosity. So this is the tibial tuberosity. So if I am following the tibial tuberosity like that, you will be able to see a bumpy thing. You can just palpate in yourself. So this will be the attachment site for the iliotibial band. So distal iliotibial tendinopathy, you will be having a pain here because where is it? It is at the attachment site. So you palpate yourself, then you will never forget. So this is known as Gerdy's tubercle. This is tibial tuberosity. Now this is tibia. This is the lateral plateau. Now this is the lateral plateau. This is the anterior aspect because now seeing from like this. So anterior aspect, you will be having a bumpy thing. So that bumpy thing is your Gerdy's tubercle. So if you have a tenderness over there, that is suggestive of your distal iliotibial band tendinopathy.
Okay,
That's
ma'am.
clear now?
Thank you. Yes, yeah, clear.
So now I'll be starting the stenoanatomy. Let me change the camera now. Okay. Can anyone help me and tell me that everything is visible to you? Anyone?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Thank you so
Yes,
much.
Visible, ma'am.
Okay. So let us learn it. And I want all of you to perform good injections for the knee because that is one second most commonest thing you will be seeing it if you are going to practice pain. Out of now, what you need to learn here, see, in ultrasound, always remember two things. First, whenever you are seeing something, what exactly should be the position to visualize? Now my patient is lying down, right? In this position, if I'm going to put the probe and I'm going to visualize the quadriceps tendon, believe me, there'll be lots and lots of anisotropy. Why? Because the quadriceps tendon will be like this. And if I'm putting a probe, my beam will not be parallel and I will be looking at the quadriceps tendon and there'll be so much of hypoechoic, means so much of black area inside the tendon. And I'll be thinking, oh my God, this patient has got a quadriceps tendinopathy. So now in order to avoid that, what you need to do is put something, make a roll and put it beneath the knee joint. So this should be the position when you are examining the knee joint. Always remember that. So first, you have to flex your knee to 30 degrees approximately because that is going to straighten up your quadriceps tendon and you will be able to visualize it nicely. Second thing, as I always say, is your probe. Can anyone tell me which probe I'm using? So you're going to get extra 5 marks. Anyone? Let me see who can answer.
Linear probe.
Wow, I'm so happy. So even if you have not seen the probe, if you are looking at the screen, how exactly the screen is looking like? It's a square shaped thing. When it's a square shaped thing, what is there? That is a linear probe. Now let us start. So I've set the frequency to 13 Hertz and my depth approximately, you can see the depth. See, I'm changing it. You can see it on this side. So I'm just keeping it 4 and because I want to see something. So focus, this arrow which is moving, yellow color arrow, see here, this is the focus. So this focus, I'm keeping it somewhere 1.5 and let me see whether I'm able to see everything nicely. If not, I will just change it. Now we are going to put the gel. See how I'm holding the probe. This is very, very important. Let me lift the camera a little bit so that you are able to see. Now, how is the quadriceps tendon coming? It is these muscles, they will be forming the tendon. Okay, let me remove this hand. I'll show you from here. So this is a tendon which will be coming and this is the patella. This is the base of the patella and this tendon will come and this will be attaching itself on the superior pole of your patella. Now, what I'm doing is, this is my probe. This probe, I'm putting it in the long axis. Are you able to see the position of the probe? No?
Yes, ma'am.
Yes, ma'am.
Great. So now, okay, my hand is disturbing you. So, okay, I'll do one thing. I will be just showing you with this hand. Though it will be very difficult for me to jelly, and I'm a right-handed person, but still we will see. Or I will do one thing. I will just take a picture of the quadriceps tendon, and then I will be freezing the image. I will be showing you the pro position. So that is going to be the best thing which we will be learning. This is how we'll be learning. Otherwise, my hand will be obscured. Now you see. Just learn the probe position first. This was the quadriceps tendon. I have put my probe in the longitudinal axis to the quadriceps tendon. This is the light. So light is my aspect marker. This aspect marker is towards the head of the patient. And I have kept it in such a way. See, when you are just beginning the ultrasound, now always make bone your friend. So you palpate the superior pole of the patella. You keep the lower end of your probe on the superior pole and then in the longitudinal axis. What you will see if you are going to do it like this, you are supposed to put the probe in the longitudinal axis, one end over the base of the patella and the other one, but the lower end should be on the base of the patella. So this is how you will be holding your probe. Now look at the screen and look at the movement of the arrow which I'm showing you. We have kept the lower end. This is the cranial side and that is the caudal side because our probe was also like that. This is the aspect marker. Our aspect marker was towards the cranial side. So this is the cranial side and that is the caudal side. Caudal side, we have kept it over the base of the patella. So this becomes the patella and this is the femur. This is your quadriceps tendon, though this is not some problem. This is just because of anisotropy. So this is your quadriceps tendon, hyperechoic fibrillar, getting attached on the superior pole of the base of the patella. Two fat pads we have learned. This triangular thing which you are able to see. Are you able to see the movement of this arrow? So this triangular thing which you are able to see, let me just see if I can draw. I have just downloaded one software, but I don't know whether it will be working. Let's see. Okay, it's working. So now this portion which you are able to see here, this is your suprapatellar fat pad and the portion which you are able to see this one, this whole from here, this is your prefemoral. This is femur, this fat pad above the femur, in front of the femur. So this becomes your prefemoral. This is the patella. This is superior to the patella. So this becomes your suprapatellar. And in between these two, this black thing which you are able to see is your suprapatellar recess. So when I'm putting my probe at the base of the patella, I should be seeing the patella. I should be seeing the femur, the quadriceps tendon, suprapatellar, and prefemoral fat pad. And in between these two, I should be able to see the suprapatellar recess. So that much is clear, I hope. Now from there, again, let me just see if my hand is disturbing you to see the probe position, then I will be just freezing it and showing you. So we were here, can't see, facing volume issue. Am I audible, sir?
Audible, ma'am. We could not
Yes,
see pointer moving, ma'am.
Audible, ma'am.
Madam, the
Pointer
drawing was not seen,
not-
madam.
Yes, ma'am.
Drawing was not seen.
No, ma'am.
Oh my God. Okay, I tried.
But the pointer was not.
Okay, no problem. I'm showing you again. Now see the movement of the arrow. I don't know why. It's not moving. Okay, no worries. We can just have a look once again. Don't worry. I'll show you once again. So let me get the best picture for you. Okay, look at the movement of this arrow. This is your patella. This is the quadriceps tendon. See, earlier it was one black dot was there. Now I have changed the angulation of the probe and now it has become hyperechoic fibrillar. So this is your quadriceps tendon. From here till here is your quadriceps tendon. Now this is the patella. So you have something like this, a triangular hyperechoic thing. This is your suprapatellar fat pad. And this one which you are seeing here, this is your prefemoral fat pad because this is femur. And in between these two, you have your suprapatellar recess, which is like this. So this is the area where we will be injecting if we want to go inside the joint. From there, what you need to do is you need to slide your probe from there. Now I will just slide it. I will show you the probe position, so nothing to worry if you are not able to see. See, my probe was like this. Now I'm holding it from there so that you can see it. My probe was like this. Again, in the longitudinal axis, we are keeping the same axis. We won't be changing the axis. It will be in the longitudinal axis. Aspect marker will be towards the head of the patient, and the position is also same. Now, from there, you need to slide your probe over the patella. So first is your lower end, this end. This is the lower end. The caudal end of the probe was over the base of the patella. Now from there, I have slided it. Now my hole, even the upper and the lower end is exactly over the patella. So that is the second movement of the probe. And now when you are moving it, we are exactly over the bone. So what we are seeing here is the patella. And these are the superficial fibers of your rectus femoris, which are going. And if you have a bursal thing, so this area will be the one which you will be able to see black thing in this area. I think I have shared the picture. So in the pictures, you can just learn about the pathologies. Right now, learn about the normal thing, how they look like. So this area, if you're able to see, because this is patella, we have learned pre-patellar bursitis. You have the bursa, which is there in the subcutaneous plane. So here you should be able to see in this plane, you should be able to see a big black thing. So that will be your pre-patellar bursa. But right now this patient doesn't have. So this is your patella. And these are the superficial fibers of your rectus femoris, which are going down. Now, learn the third probe position. Again, third probe position is, let me repeat once again so that you remember the probe positions, because this is very important. If you know this, knee is the super easiest joint to scan. First, the probe was in the longitudinal axis, aspect marker. See the light you can see on the screen. So that is the aspect marker was towards the head. Probe was in the longitudinal axis to the quadriceps tendon. From there, we have come over the patella. And from this patella, we are gonna move down. So let me move down and then I will be again sharing with you how to go about. From there, now look at the probe position first and then I'll be explaining you the image. So now this hand was over the patella. Now from there, exactly in the same plane, I have slided my probe down, keeping the aspect marker towards the head of the patient. So when I have moved down, we have learned if we are going to go beneath the patella, the apex of the patella, we should be looking at the patellar tendon. And we have learned that the patellar tendon will be getting inserted on the tibial tuberosity. So now you see, this was the patella lower end, and this is the tibia starting up. But this is not the tuberosity. I will be again sliding my probe down to show you how exactly the tibial tuberosity will look like. So just for the time being, what you need to remember here is this side, this is the apex. Now, because from the base, we have slided our probe down. So we have come to the apex of the patella. So this is the apex of the patella, and this is the tibia, which is starting up. This is your patellar tendon. Tendons in the long axis, they are hyperechoic and fibrillar. This is your patellar tendon, or if somebody wants to call it as a ligament, they can call it. It's up to you all. So this is your patellar tendon, and this is your infrapatellar fat pad. This is the one which is beneath this tendon. That's why we call it as infrapatellar, something which is below something. This is your fat pad. This is your tendon on one side because our probe was in a craniocaudal direction. So cranial side, we had our patella. So this must be the patella and this must be the tibia. I hope that much is clear for you. Let's have a look how far we have to go in order to scan the patellar tendon. From there, now just look at the screen. I'll just show you the movement and then I'll explain you. From there, don't stop there. Once you are able to see this hyperechoic line, don't stop there. Let me apply some gel, otherwise it will be all moving thing and we'll be able to see all the black areas. Again, from there, I am coming down, down, down. Now, till this, you're able to see something like this. So till, okay, let me stop it here. Now, this is the attachment. This is the tibial tuberosity. So tibia started from here, going, and now you see a bumpy thing over there. This bumpy thing is your tibial tuberosity, and this is your patellar tendon, which is getting inserted here. So you need to follow it fully up to its insertion. Do not stop here once you start looking at this white hyperechoic thing. And now learn the position of the probe for it. So first we have checked here quadriceps tendon, then we have come over the patella, then we have come over the infrapatellar area, and then you should slide it until you see the attachment of your patellar tendon. So these are the movements of the probe, and this is exactly what you see in the anterior aspect. Now, we have talked about the infrapatellar, superficial, and the deep bursa. This is your tendon. You have to stop when this patellar tendon is getting inserted on the tibial tuberosity. This is the tendon. So on the top of the tendon, this is the subcutaneous tissue. So in this, if you are able to see some bumpy thing here, this is your skin because it is hyperechoic, and this is your subcutaneous tissue. So some enlargement, if you are able to see at the same time when you are putting the probe, this is known as something called as an ultrasound probe tenderness. When you are trying to press it, the patient will say, no, please don't press it. Even with the slight pressure, the patient is going to have pain, and that is known as probe tenderness in ultrasound. So you can have the probe tenderness if the patient has got infrapatellar superficial bursitis, means there is something which is over this tendon. So this is your infrapatellar superficial bursa, and this is your deep bursa. Always in the deep bursa, you will be able to see accumulation of the fluid, which you are able to see here right now. And that is a normal physiological thing. Please do not think that this is abnormal. So that was all about the anterior aspect. Any doubt in the anterior aspect? Or I'm just moving to the medial one now. Anything you want to see again, you have not understood?
Ma'am, please continue.
Okay. Fine. So this is all about the anterior. So let me remove. Just give me a second. I will stop. Second thing, if you want to go for the medial, now medial is this side. What you need to do, you need to abduct your hip joint. Just the camera. And just flex the knee. No, it's visible. But here. I hope it's visible now. Now again, what you need to do, every time palpate and then put your probe when you are just learning the ultrasound. What you need to do is, this is your tibial tuberosity. From there, keep on moving up. This is your joint line. What you can do when you are just doing a diagnostic scan, put one finger over there. So then you will see how easy it is to just identify the structures and just identify the things. This is your joint line. See, you're able to see some dip there. So that is your joint line. What you need to do here is, now probe is again in the longitudinal axis. This is the aspect marker, which will be towards the patient. So first we have learned the position, then we should learn the probe position also. So the probe position, again, it is in the longitudinal axis. The aspect marker is towards the patient. Either you put a finger over there and then you put your probe. Now this probe is not in the longitudinal axis. This probe is not in the short axis. This probe is not in the sagittal axis. This is in the coronal axis. Why? Because I'm looking from this side, this side. This is how our coronal sutures are. So this is the coronal plane. Little oblique you have to keep your probe. And let me reduce the depth because we'll be seeing it very superficially. And frequency is the same. And I've just reduced the depth to 2 because it's very superficial. You do not have 4 centimeter depth. What you need to do, again, you just put your probe there. And I'm freezing so that I can explain you. My probe position was like this. This was the aspect marker which was towards this patient. This becomes my cranial side. And this becomes my caudal side. We are looking at the medial joint. We have just kept our finger over the medial joint line. So this one, this black thing beneath this hyperechoic thing is our joint space. The upper one is our femur and the lower one is your tibia. This triangular hyperechoic thing which you are able to see is your meniscus. Now you see you are able to visualize only a portion of your meniscus. And meniscus is it's a fibrocartilaginous structure. That's why this structure is going to be hyperechoic and fibrillar. So on the top, femur, one hyperechoic bone, down is your tibia. In between these two, this hyperechoic thing is your meniscus. Now on the top of the meniscus, what you are able to see, something which is going is your medial collateral ligament. So meniscus pathology, if there is something, you have a cyst, then this portion will be going up. If you have a ligament problem, if you have the medial collateral ligament tear or something, you will be able to see the inflammation around this ligament. Or if there is a tear, you will be able to see some hypoechoic area in this whole thing. So that's why you will not be able to find out all the pathologies of your meniscus. That's the reason if you are doing a diagnostic scan for your meniscus, USG is not the diagnostic modality, MRI is the diagnostic modality of choice. That was about the medial side. And coming to the lateral. For lateral, again, learn the position. Now lateral, you have to just do the opposite thing. Here we have adducted, flex. Here it's the adduction and then little bit of extension. Little bit of flexion is more than sufficient. Now I've asked him to take a lateral turn so that it is easy for him. Otherwise, just lying down in this maneuver is going to be little, uncomfortable for the patient. What you can do, this is adduction. You keep this, again, I have not removed it, so we can just keep it. And the knee is flexed, hip is adducted. What I have told you, if you want to look for the iliotibial band, what you need to do, you need to put your probe from femur to tibia. And if you want to look for the lateral collateral ligament, your probe should be from femur to fibula. Again, the probe is in the longitudinal axis. First, we have learned the position. Now we should be learning the probe position. This is the aspect marker, which will be towards the head of the patient. Again, what you need to do? You need to palpate the Gerdy's tubercle. So this is the Gerdy's tubercle. We have palpated. If not, what you can do, just palpate the joint line, because the joint line will be between femur and tibia. If you are not able to find the Gerdy's tubercle, no worries. Palpate the joint line and then again put your probe. The depth and all, is the same. Focus also is the same. Okay. So this is the probe position. It is from femur to tibia. This is very important for you to know, because when we are looking at the lateral ligament, you will see that the probe position is going to be like this. So here the probe position is from femur to tibia. Tibia is this side. This is the tibial tuberosity. So our probe is like this. Again, in the coronal plane. Okay, let me show you again. So the probe is like this, from the femur to the tibia. And this was the aspect marker towards the cranial side. Now look at the image. This is the aspect marker. It was cranially. So the cranial portion will become our femur, and this portion will become our tibia. Femur, tibia. This is going to be our lateral meniscus, and this black thing which you are able to see here is our joint space. Now see the hyperechoic fibrillar pattern, which you are able to see very nicely, is your iliotibial band. Now always remember that iliotibial band, here it is thin, 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 and but if you see at its attachment side, it is broader. So always this iliotibial band, whenever it's inserting on the Gerdy's tubercle, you will be able to see the lower end is an expanded form. It is not just thin. So do not get confused. Oh my God, this patient has got a tendinopathy, which madam was talking. No, this is the normal iliotibial band insertion. You have an expansion when it is attaching itself on the Gerdy's tubercle, and you can see the whole insertion of it on the Gerdy's tubercle. This is your Gerdy's tubercle. So that was about the iliotibial band. Now we'll be learning the lateral collateral ligament. Now for the lateral collateral ligament, position remains the same. Probe also is in the longitudinal axis, aspect marker is towards the patient. Now here, what you need to do is, again, you palpate. Always remember one thing, that here from the tibia, go towards the lateral side. Then that is your fibula. So now this is the tibia. From tibia, I'm just moving little laterally. So if I'm moving little laterally, I'm able to feel fibula here. So this is the fibula, and this must be the femur. So this should be the direction of the lateral collateral ligament. Always, always, always have in your mind how exactly that structure will be present and how exactly are we supposed to keep our probe. If you will keep your probe exactly in that position, you will be able to see that structure very nicely. So probe should be in this way. If you are going to put your probe like what we have learned to the anterior aspect, you like this, we have looked for the iliotibial. Now like this. Now from the femur to will come to the fibula. Fine. Let me show you the whole thing. This is not fibula. This is fibula. I'll be showing you again, but for the time being, you remember, then I'll be showing you the, the femur also. Do not get confused that this is my tibia. Now see how to see that this is femur and this is not tibia. I'm just showing you first two, because when I started now, I also used to do this mistake. I used to think that is only the tibia. Now see, I'll show you. This, if you look at this bone, how this bone is, it is coming, having a dip here, and then it is becoming rounded. So this dip is basically the side for your popliteus tendon. So this is your femur. Femur, the lateral epicondyle, it is always, the lateral side is like this. Remember this picture throughout, you will never be wrong. So this is your femur. Femur will be like this, then you will have a dip and then going up. So this will be the side for the popliteus tendon. Now you see, again, I have palpated the fibula. So if I am looking at the fibula, how the fibula should be, it should be like this, crescent shaped thing. Okay, let me freeze it so that I can just show you nicely. It will be a crescent-like shaped thing. So this crescent is going to be your fibula. Now, something which is lying down here, this is your T. And for one thing, if still you get confused, between the femur and the tibia, you have your meniscus, but between your tibia and the fibula, you don't have your meniscus. So that is another way. This is the superior tibio-fibular joint. And this hyperechoic thing which you are able to see here getting inserted on the fibula is your lateral collateral ligament, this one. So I will be showing you now again fully. We have learned all the parts. So now let us see it once again from up to the down. So this is femur. Okay, my hand is there. I'm sorry. Now I think it is. Oh, yeah. My hand is not letting you see the pro position, but if I'm holding it from there, it is slipping. Okay, we'll try, not a problem. So from there, see, I'm sliding. So that is where the arrow is moving. It is moving. So that is our femur. So from there, we are sliding down, down. Now something which is sleeping has come. So that is our tibia. From there, now one big bone will come. So that is our fibula. And the hyperechoic thing which you are able to see here is your lateral collateral ligament. So that was all about the knee joint. And then I will come back again to the ankle. Any question you want to ask?
Yes, ma'am.
Yes.
Ma'am, in this, the lateral collateral ligament appears to be hyperechoic.
It should be hyperechoic fibrillar.
No, as in it appears like a bony margin, which is usually not present. Like
See,
this.
one thing I'll tell you, what mistake usually we do is, say, if the lateral collateral ligament is like that, we need to stretch it, right? What people will do is, when your ligament is like this, okay? Your ligament is like this. We are looking it in a, stretched manner. But if
patients like, yes, now it's visible.
is it visible?
Yes.
I'm sorry for that.
Yes, ma'am, now it's visible.
Okay, let me show you one second. This is the wrong position. Put it down. This is the wrong position to examine it. Why? Because the lateral collateral ligament will sag.
Okay.
Okay, that is the reason we have put this, right? Why? Because if you would have looked at the quadriceps tendon, that time also you will not be able to see it like that. But if we have stretched it, so now the ligament is stretched, and the other position some books suggest is like you should see this ligament like that. But I found this position very uncomfortable, so I follow this so that this ligament is fully stretched. I hope that clears your doubt.
Yes, ma'am. Thank you.
Excuse me, ma'am.
Yes.
Ma'am, some patients complain of pain which starts from back and radiates to the knee and suddenly stops there. Then what can be the cause for those pain?
So many causes are there. You can have an SI joint pain. You can have a facet joint pain, right? And if you can have a disc prolapse at your L2, L3.
So we should get an MRI done for
have
that.
a hip pathology also. So what you need to do is, like I have not shown today because I have to take ankle also. The examination part is really, it should be taken for hours together.
Yes.
See, you whenever, okay, since you have asked it, so I'm showing you so that we don't do a mistake when we are examining a patient.
Okay.
Fine. So this is only.
Thank you, ma'am.
So let me just again change the things. Somebody wants to see ACL. ACL, if I complete the class, you stay back. I will show you. Or else I will send you a video link. You can see. Nowadays, we are having our separate presentation. Somebody wants to see that. I will be sharing a video link. So you will be able to see that. This is the hip. Now, always, whenever you are starting a knee examination, do an internal rotation and external rotation. Do in hip extension and then in hip flexion. So this, if the patient has got any hip pathology, you will be ruling it out. So this is just the, you're starting the knee examination. I always do that. I do not start with the knee first. I always start with an SLR. Okay. So SLR, I always start with an SLR is just straight left. So this is what, if the patient is complaining, suppose you're lifting it up and the patient, no, don't do that. It's very painful. I'm having a pain here. So this SLR is positive. You start with an SLR, then you do an internal and the external rotation of your hip in extension as well as in flexion. Fine. So roughly you are ruling out, and then you start with.
Okay, ma'am. Thank you. Thank you.
So now I'll just take your ankle, not your ankle, my ankle. So let me just share the screen. Ankle, I'll be just little faster. So we stopped here. So again, Mali, all your doubts I'll be taking after this presentation because quickly I should finish it up. Otherwise, all of you will get bored. So, okay. When we are talking about the ankle joint, what exactly is ankle joint? Ankle joint is the synovial articulation between the lower end of your tibia, fibula, with the dome of the talus. This you should remember. This is the talus. Talus has got a head. You have talus has got a neck, and then this is the body, and the superior portion of the body, we call it as dome of the talus. So this tibia, fibula will be articulating with these dome of the talus to form the ankle joint. It is also known as talocrural joint. So if you can find somewhere written like talocrural joint, do not get it confused. It is one and the same thing. So today we will be talking only about this. This is basically comes in foot, which we won't be discussing today. This is very important. Listen to this slide very carefully. I have deliberately eliminated the nerves part because I will be taking your nerve class, lower limb. And so that time I will be discussing about all the nerves. So forget about the nerves right now. Just remember these tendons, and I'll just give you a trick also to remember it. This is the anterior ankle. Anterior ankle, just remember 2 points. 1 point, the anterior compartment is your dorsiflexors. Means when these muscles, they are going to contract your foot. This is foot, so your foot will be like this towards you. So this, they are the dorsiflexors. Whatever we are learning, either the medial, either the anterior side, remember 3 tendons are there. 1 tendon will be for your great toe. Great toe. Great toe, we call it as hallucis. And when it comes to your thumb, you would have learned it in your wrist class. We call it as pollicis. So when I'm saying extensor hallucis longus, means extensor, this is a muscle which function is extension. Hallucis, this will be for great toe. Longus, that is a long tendon. So extensor hallucis longus. You have 1 tendon for your great toe, and then you have 4 tendons for the other toes. So other toes, it is always called as digitorum. Digitorum means for the digits, whatever digits you have. So hallucis and then digitorum. These 2 will be there if you see the medial compartment or if you see the anterior compartment. Anterior compartment, we call it as extensor hallucis. Medial compartment, we call it as flexor hallucis. Anterior compartment, we call it as extensor digitorum. Medial compartment, we call it as flexor digitorum. I hope that is very much clear to all of you. Now, 2 extra tendons are there in the anterior and the middle compartment. They are tibialis anterior. This mnemonic, this is wrong. It is TA. Tibialis anterior and then tibialis posterior. If it is in the anterior compartment, it becomes tibialis anterior because we are talking about the anterior compartment. If it is in the middle compartment, we call it as tibialis posterior. Just remember these 3 things, and they are going to be the same whether I'm talking about the anterior ankle, or I'm talking about the medial ankle. medial ankle. So anterior, this is again wrong. This is tibialis anterior. I don't know, maybe yesterday night I was a little bit tired and I was making this PPT. So in deep sleep somewhere I have written something. So don't mind it. What I am just telling you, listen to that and do not remember it also. This is tibialis anterior. So tibialis anterior we have. Then we have your extensor hallucis longus. This is your extensor hallucis. You can see in this picture, this is for your great toe. Then you have the digitorum, which is for your digits. And they are the dorsiflexor. So you will be asking the patient to go for an dorsiflexion if you want to test for the tendons of the anterior ankle. Now, second thing which I would like to tell you is this ligament. So this ligament is a syndesmosis, means this is something which is a fibrous connection between the lower end of your tibia and the fibula. And we call it as anterior tibiofibular ligament because it is connecting the tibia and the fibula. So you should know these tendons and you should know this ligament when we are talking about the anterior compartment. Coming to the posterior compartment, I will be showing you the Achilles tendon today. How Achilles tendon is formed. You have a medial gastrocnemius, which is there on the medial side. Then you have a lateral gastrocnemius, which is on the lateral side. Now, these two will combine to form a tendon, as you can see in this picture. Now, beneath this, you have your soleus. Now, this soleus will be having a central tendon, and then this will be joining these two. The tendon, which will be formed by these two muscles, muscle will become tendon. So these two muscles, one on the medial side is your medial gastroc, on the lateral side is your lateral gastroc. Now, both of them, they will be combining together to form a tendon, which will be joined by the tendon of the soleus, which is present beneath this muscle, as you can see in this picture. Now, these three, they will combine to form a tendon, which is known as Achilles tendon. And this tendon will be getting inserted on the calcaneus bone. So this is your calcaneus bone, posterior surface. So this tendon will be getting attached here. Two ligaments, one will be from tibia, from fibula to the tibia, and another one from the fibula to the talus. These two ligaments, they are very strong ligaments. So until and unless you have a dislocation of the ankle joint, they are not going to get torn. So there is no point in learning something where you have a dislocation, because if there is a dislocation, we'll be sending this patient to our orthopedic friend. So we are a little relaxed. So what is the take home messages? These ligaments are very difficult to tear. So let's not talk about these ligaments. We'll be talking about the Achilles tendon. Remember one thing, what I have told in my basic class, that tendon will be enveloped by a sheath. So this sheath has got a visceral component and the parietal component. So between these two, you have a gap where the fluid will get accumulated, and we call it as tenosynovitis. And if you remember, I have told you in my first basic class, this Achilles tendon doesn't have that. It doesn't have a covering. You will just find a connective tissue layer which will be covering this Achilles tendon, and that is known as paratenon. So somewhere in your books, you will find it paratendinitis. So do not get confused. What is this? We have never learned. It is nothing but Achilles tendinitis. So after that, let's see two bursas. Usually when we examine the Achilles tendon, we will be examining it from the posterior aspect. So posterior aspect, if you are able to see a bursa, which is on the top here, so that becomes your subcutaneous bursa, because it is on the top. It's like your infrapatellar superficial bursa. You have a tendon, and on the top of tendon, you have a bursa. Now this is your retrocalcaneal bursa. It is beneath the tendon, but it is outside your calcaneus bone. So this, in between these two, you have a bursa, and this becomes retrocalcaneal bursa. Retrocalcaneal bursa inflammation will become retrocalcaneal bursitis. Achilles tendon problem, Achilles tendinitis, paratendinitis, that is a right way of saying, because now many nomenclatures, they have been changed. And second thing, if you have an inflammation of this bursa, we call it as retrocalcaneal bursitis. Both these things can present with heel pain or pain on the posterior aspect of your ankle joint. Then on the medial side, so remember that whatever is coming to the medial side, these muscles, they take its origin from the posterior side. So posterior of your leg, you have a superficial layer and you have a deep layer. So superficial layer, medial and the lateral gastroc, along with the soleus, they will combine to form the Achilles tendon. So that is a part of the superficial layer. And if you come to the deeper layer, again, you have 3 tendons. How easy was it to remember those tendons? One is your tibialis posterior, then is your flexor hallucis longus, then is your flexor digitorum. So 3 tendons, they are from the deeper layer, which is present on the posterior aspect. Now, all of them, they will descend down and then they will take a turn and they will be inserting on the sole of the foot. So that is how, and their function is plantar flexion. Same function is for the Achilles tendonitis. It is a plantar flexor. So dorsiflexors, they are the anterior compartment. Posterior as well as the medial compartment, they are the plantar flexors. Now, on the medial side, you have the deltoid ligament and the spring ligament. This, if you want to read in detail, I have sent you a video, and this class was taken by me, this ligament class. So you can just go through. Tendon also, the class was taken by Devjyoti boss. So if you want to learn in detail about the tendons, so you can just refer those videos. Now, this ligament is a very strong ligament, very, very strong ligament. And the chances of getting it, like there is some pathology of this tendon, pathology of this ligament, I'm sorry, is little difficult. And this ligament will get, you will have a problem with this ligament when you are going to have the eversion injuries. And eversion injuries are less common as compared to the inversions injury. Means how we will slip in the bathroom. Our leg will be like, our foot will be facing towards us. So these kind of injuries are very common rather than the injuries where your sole of the foot is facing outwards. Usually in the bathroom, all of us would have slipped once. So that is inversion injuries. They are more common, and this get, you have the tear of this ligament when you have the eversion injuries, and which are there. That's why the ligament, this is a very strong ligament, and the injuries are little, not very common, I should say. Then coming to the lateral side, you have 2 tendons, peroneus longus and brevis. So they are the, they do the eversion of your ankle joint. And you have 2 ligaments, calcaneofibular and anterior talofibular. These anterior talofibular ligament is the most commonly injured ligament, which you see, and I will be showing you a very super easy way to find out this tendon. And believe me, if I have done lots and lots of ADFL, and that is one of my favorite ligament, because, and this PRP in this ligament is very rewarding. So if a patient comes to you that recently I had a fall in the bathroom and I have taken all the medicines, because usually just it's an ankle sprain, it will heal within 6 to 8 weeks with the rest, with your RICE protocol. And if it doesn't, then it is progressing towards the tear. So that time, giving a PRP injection is going to be very, very rewarding. So ATFL is the most commonly injured ligament. It is from the fibula to the talus. And then you have your calcaneofibular, that is from the calcaneum to the fibula. So they maintain the lateral stability. Medial side, the deltoid ligaments, it maintains the medial stability, and they for the lateral stability. And the ligaments which are joining the tibia and the fibula, they maintains the anterior stability as well as the posterior. Then this is the plantar fascia. Plantar fascia is now a misnomer. Plantar fasciitis is a misnomer, sorry. What is plantar fascia? So let me just come to that first. Plantar fascia, when we say, it is the condensation of the deeper fascia which is present in the sole. And what exactly is this? The inflammation of this, we call it as plantar fasciopathy nowadays. We don't call it as fasciitis. They say that this is the condensation of the fascia. And this central portion, we call it as plantar aponeurosis. On the sides, which you are able to see, on the medial side, that is the medial plantar fascia, and on the lateral side, it is the lateral plantar fascia. And remember again that this plantar fascia is going to be hyperechoic and fibrillar. Why? Because the collagen fibers are arranged parallelly in a longitudinal manner. So if you are looking at the plantar fascia, it should be hyperechoic and fibrillar. And I'll be telling you again a tip, because when I started USG, I never used to find the plantar fascia, and I never knew this thing also. I'll tell you what exactly is that. Do remind me when I'm just scanning. What happens? This plantar fascia will be attaching on the medial tubercle of the calcaneum. Why it is not called as fasciitis? It is because what recently they have found is it is always better to call it as fasciopathy, because it is less of inflammation and more of degenerative things. Like you would have learned in the elbow, we no longer call it as tennis elbow, golfer's elbow. We call it as lateral or medial epicondylosis, because what they have seen in the histological things that these patients who are having these conditions, the inflammatory component is not there, but the degenerative component is there. When I say degenerative, what exactly that means by, I have told you that there is a parallel arrangement of this collagen fibers. So what happens? These collagen fibers, they will be breaking down. You will be having the apoptosis. And then it is from inflammation, it is progressing towards the degenerative side. And then you will have a partial tear, or sometimes, that is very rare actually, you can have a complete tear of this fascia. So it is a degenerative thing which is going on, and it is more common. Do remember this. If it is more, because it's a degenerative thing. So if an elder person who comes to you with a pain on the heel, and I'll be showing you the palpation quickly. So if you have a pain there, so think of this could be one of the reasons for that. It is more common. One thing is like person whose shoe is not proper, so the arch is not maintained. It is more common in individuals who are obese. You have the systemic diseases like rheumatoid arthritis, all those conditions, you can have the inflammation of this fascia. So if just an inflammation, but still they say, you can call it as plantar fasciitis if just an inflammation, but it is always better to use the term fasciopathy if the patient has come to you for like after 1 month, 1.5 months. No need to call it as fasciitis, because that time the inflammatory component will not be there, and it will be more of a degenerative component. Okay, so I'll just quickly show you the palpation and the range of motions, and then we can just see a few things from the ankle joint. Because ankle hole is not included in the basic course, I'll be showing you the most important pathologies, the normal sonoanatomy of the most common pathologies of the ankle joint. So let me call the volunteer and let me stop sharing the screen. Give me 1 second, I'll just call him. So first, this is just learn the movements, because this is more important. This is dorsiflexion. This is plantar flexion. This is eversion. This side towards me is inversion, and this side outside, the sole facing outside, is your eversion. Fine. So these are the movements. And what is more important, if a patient complains of pain in this area, so let me bring it closer to you because it's ankle, so that you should be able to see it nicely. If a patient complains of pain in this area, what could be the pathologies? See, you can ask the patient to do a dorsiflexion. Once he is doing the dorsiflexion, the EHL will become very prominent. So if next to the EHL on the medial side is your tibialis posterior. Okay, let me show you in this. So flex karo. So this which you are able to see here is your tibialis anterior. So if the patient is complaining, if you have a tenosynovitis of the tibialis anterior, the patient will be having the pain here when you are doing a dorsiflexion. You'll be saying, don't do it, it's very painful for me. And exactly you'll be telling you it's somewhere here. Then if the patient is complaining of pain here on the anterior aspect, okay, I'm just tilting it down so that you can see it nicely. Here you have your anterior tibiofibular ligament. So if you have a pathology of there, the pain is going to be somewhere here. ATFL, this is your lateral malleolus. Behind that, if the patient is complaining of any pain behind this, so that is suggestive of tenosynovitis of your peroneal tendons. If you come from the peroneal to the calcaneum, if he's showing pain somewhere here, and this pain is getting aggravated on dorsiflexion, so this is your calcaneofibular, this side. Fibula, calcaneum, this side, the ligament. On the top is the tendon. If this is the lateral malleolus, oh, I'm showing it wrongly. Do it there. Sorry for that, actually. This is the lateral malleolus. So lateral malleolus, behind the lateral malleolus, if the patient is having pain, so that is suggestive of peroneal tenosynovitis. If this is the lateral malleolus, this is the calcaneum. From the lateral malleolus to the calcaneum, if the patient is complaining of pain in between these two bones, suggestive of calcaneofibular ligament problem. And if you do the dorsiflexion, this pain will be getting aggravated. Fine. So lateral malleolus, calcaneum, here is the ligament, behind is the tendon. Now from the fibula, if you come little anterior, so if the patient is complaining of pain in this area, that could be because of ATFL. And this ATFL, you do a plantar flexion, this pain is going to get aggravated. Medial side is not very common except the tibialis posterior, which comes, so this is your medial malleolus. From the medial malleolus, the tibialis posterior tendon will come like this. It will go and it will be attaching here. So if the patient is complaining of pain in this direction, here, from here to here, and if you do a plantar flexion, the pain is getting aggravated, that is suggestive of your tibial posterior tenosynovitis. So that was just a rough of the ankle, because ankle, the tenosynovitis and the ligament injuries are very common rather than any other thing which is there. So ligament ATFL, you will be seeing it daily. If you will see your 10 patients, one patient will surely be of ATFL because this is that much common. Fine. So I'll just quickly demonstrate you because I think it's already 7:45. You have to do your Kahoot also. Otherwise, then. Okay, let me start the examination. I'll just put it there. What I will show. ये दिखा देते हैं पहले पीछे. Let me focus it there. पूरा पीछे आ रहा. एक काम करो, टेबल को. I hope you're able to see.
Yes, ma'am.
Yes, ma'am.
Great. So if today, what we are going to see, first we are going to see three things which are very, very common. One is your Achilles tendonitis. So Achilles tendonitis, this is your Achilles tendon, what you are able to see here. So if there is a problem in this tendon, so you will be having either the pain where it is getting inserted or the patient will be saying, I'm having pain in this whole area. If it is associated with your retrocalcaneal bursitis, then obviously the whole area will be painful. First thing, the position, do remember this position. Now you see when he is hanging the foot is exactly away from the table. Until unless I press it, it is not like this. So it is away from the table. So if you have a tear of this, then what will happen? As soon as you will ask the patient to lie down, the foot will be like this. So all these small things, even from the position itself, you can make out what exactly is the pathology. Now let's see. Here's the jelly. What I will see, what you can do if the patient is not able to do, you stand in such a way that you have pressed this foot exactly to the table, or you can ask the patient to do so. The probe is again in the, let me freeze it. Probe is again, frequency again 13 hertz I'm using because it's very superficial. My depth, as you can see, it is 2 centimeter. The probe is in the longitudinal axis. This is the aspect marker, which will be towards the patient side. What you need to do is you put your probe in the longitudinal axis. First thing I would tell you is look for because this is the cranial side, that is the caudal side. Caudal side, you should be having a bone, and the cranial side, you should be having your tendon. So what you should see on the caudal side, try to look for an hyperechoic structure. So let me freeze it. I will explain you. I need to increase the part from now. Okay, I will do one thing. I'll just change the camera because the machine is a little far from me. So I'm just finding it little money. My machine is a little far, so I'm not able to put the knobs, and then it will be difficult for you to understand. So just bear with me for the technical things. It happens. Now, again, I'm showing you, so nothing to worry. The probe is in the longitudinal axis. Now, I'm able to look something there, hyperechoic thing. Now, I'll just freeze it. Position you have understood, probe position you have understood. Now, look at the arrow and try to learn this, how to look for the Achilles tendon. This is our calcaneus bone. This hyperechoic fibrillar thing is our Achilles tendon. Now, if you have a bursa, so this is the tendon. In this plane, you will be able to see the collection of the fluid. This is the tendon. If you have any inflammation of this tendon, you will be having either you will have a bursal enlargement, will be in the subcutaneous plane, or if there is a paratendinitis of this tendon, the tendon will appear swollen to you, and you will be having the collection of fluid around this tendon. Second thing, if there is a tendinosis, you will be able to see the hypoechoic areas in this tendon. So that is tendinosis. Then this is the tendon, so it is getting inserted. This is the bone, calcaneum bone. You will be able to see the bursa enlarged. Now he doesn't have any bursa. Otherwise, if there is a bursal enlargement, you will be seeing in this plane. Now, this is the bone and this is the tendon. So if we are able to see any collection of fluid in this area from here till here, so that is our retrocalcaneal bursitis. If we are able to see the fluid there, then only we should be calling it as bursitis. Otherwise, if there is no fluid, there is no distension, we need not call it. And now what you are able to see here is your Kagger's fat. Again, I'm repeating, this is your skin, very thin subcutaneous layer, then your Achilles tendon, calcaneum bone, retrocalcaneal bursa here, and this is your Kagger's fat. So this is about the Achilles tendon. Now I'll be showing you the plantar fascia. Again, I'm defreezing. Depth I'm keeping the same because that is again going to be very superficial, and focus also it's like somewhere beneath, somewhere above 5. I think it is 6 or 7. Now for the plantar fascia, because we know that it is attaching on the medial tubercle, what you need to do, this is toe, this is your second digit. Approximately draw a line from the center and keep your probe in the longitudinal axis and ask the patient so that you are stretching the plantar fascia. Now you put your probe again in the longitudinal axis. This is the aspect marker above, and then this is the caudal portion. Now you see, I'm not able to see anything. So I'm thinking there is no fascia. What you need to do, keep on increasing the gain because the sole is very thick. So the signals, you will be finding it very difficult to see the plantar fascia until and unless you increase the gain. So that is the tip which I wanted to give you. Now my gain is approximately 95%. Earlier, the gain which I was using was 62 or 60%. So see, if I have not increased the gain, it would have been difficult for me to look at the fascia. So that is the setting you should be doing if you're not able to see the fascia. And that was a tip which I wanted to give you because this has happened with me in the initial days. And I never read it, to be very frank. And then later on, yes, the teaching started, we all learned from our mistakes. Okay, this was the mistake which we were doing. So I will show you the fascia. Let me just get a proper image for you. Probe is in the longitudinal axis, aspect marker is this side. I have asked the patient to press on the edge of the table. Fine, so that was a probe position. Now look at the image. This is a bone because the fascia will come from here and then it will be attaching on the calcaneum bone. So we should be looking at an hypoechoic structure on the top. And this fibrillar structure which you are able to see, this is your plantar fascia which is getting inserted here. And this which you are able to see is your muscle, that is the flexor digitorum brevis muscle. So if there is an enlargement, if you want to measure it, like I'm just telling you, showing you how to measure it because this is very important. Okay, so let's see how much is the thickness of this. Now, see the thickness is approximately 3 mm. Some book says it is if it is more than 3.5 to 4, that is suggestive of your thickening of your fascia, means there is some pathology which is going into this fascia. So always whenever you are looking at the fascia, you try to measure it, what exactly is the thickness, and if you are finding the thickness more than, I should say, 4, then that is suggestive of pathology of this plantar fascia. So that was all about the plantar fascia. The only last thing which I need to show you is your ADFL. So again, I need to change the position. Malik, वो कहाँ बोलो? ऐसे रखो, ऐसे हो जाओ, बस. बस. So now I have changed the position. I have asked the patient to lie down in the lateral position, and I have kept this roller again, which we were using for to see the quadriceps tendon here, and so that this foot is hanging, and if I want to go for a dynamic scan, I can do that. 2 ways to find it out. So let us learn the easiest way, and then I'll be telling you the difficult way also. So whichever you are comfortable, you can use it. What we are supposed to do now is I'm just increasing the depth approximately 3 centimeters. I hope this will be more than sufficient, and if not, I'll increase it further. Okay, let me reduce the gain. Still, I'm not happy with the gain. Now it's fine. Now, anywhere you can put, this is the lateral malleolus. You palpate the lateral malleolus. Put your probe. Now the probe is in the short axis. This is the aspect marker. This is towards this side, lateral side. And this is the medial side. Put your probe anywhere. Just palpate the lateral malleolus. in approximately 3-4 centimeter, whichever you are comfortable. You put your probe. What you need to just follow this, because this is the easiest way of going for an ATFL, and believe me, ATFL is the most rewarding thing. This is fibula. How can you remember this fibula? This is like the shark fin. So this is your fibula. Now from the fibula, you keep on coming down, coming down, coming down. I'm just coming down in the same position. I'm coming down, down. I'm almost over the lateral malleolus. Now, what I am going to do, what you are able to see is the another bone which has appeared here on the medial side. Let me show you. I increase the depth so that it is visible. So now one more bone has come here. Obviously, if this is the fibula, this must be the tibia. Again, you see, so that you do not forget it. This was the bone which we were looking at. This muscles and all I will show you, don't worry. When I will be showing you the superficial peroneal nerve, that time I will show you. So just concentrate on what I am telling you right now. So this is the bone, this is our fibula. Probe, how the probe was? Probe is in short axis. What am I doing? I am just moving this probe caudally. Caudally. Now there is nothing here. There is all muscles. Then I am, now there is something which has started coming up. Now I am again moving, moving down, down. So now see, this has come up. Let's go down and let this bone go up. Now you remember the contour of this bone. This is tibia, still tibia. I'm coming again, still tibia. Now see, tibia is getting now no longer tibia is there, it is getting disappeared. I need to hold the probe like that. Otherwise, I will not be able to show you. And then don't worry, I'll be showing you the probe position once again. From there, tibia has gone. Now something like a mountain has come. Let me show you. This is still the lateral malleolus. Now the tibia was almost there, and now something like this has come. And on the top of that, you are able to see one hyperechoic thing which is connecting this bone to this bone. This is your ATFL. ATFL has got two bands, superficial and deep. So we'll be seeing it once again. Let's see. From there, again, just concentrate. That is our fibula. What I am doing, probe is in short axis. I am moving from there, coming down, maintaining the same axis. I have not changed anything in the probe. Same thing. Now I am over this. And now this mountain, something like this has come. Now I'll tell you a trick. Now, once it has come, what you need to do, you angle your probe in such a way that this caudal portion, this was the aspect marker. So this is the lateral side. Now, this side of the probe should be pointing towards your greater toe. So see, if I am here, I was here. Now that is my talus. So here, you just see whether your probe is exactly pointing towards the talus or not. And when it is pointing towards the talus, you can just see the movement. You can just see the movement of that hyperechoic structure. So that is your ATFL. So that is the easiest way of finding it out. And if you want to go for an injection of this, because it is very superficial, you can go for an out of plane technique, or you can go in plane from this side. From the side which is pointing towards your greater toe, means from the medial side. Okay, let me hold it like that so that you will be able to see. And you can go from this side. So that is about the ATFL. Now, one basic thing which I want to tell you, whether it is any procedure you want to inject. Suppose I'm just giving you an example so that you don't do any kind of mistake anytime. Supposedly, because learning the needling is also very important. rather than identifying the pathology. Needling is also very important. So learn the things, learn the basic, and then any way you want to do, you can go for it. So just turn, Mali, turn. Very basic thing I'm telling you. So just try to see. I'll be showing you with a needle so that it is easy. Where have I kept my needles? Needles कहाँ गए? अभी थी ना एक. अच्छा. It is here. Now see, this is applicable for anything you want to do and need. Just try to see. Supposedly, I'm looking at the Achilles tendon. Let me hang it. I want to go for a needling of this tendon. What are the ways I can go for? This tendon is in the longitudinal axis. Either I can go from here. If I am going, okay, my hand is disturbing you. Now you see. Then it will be slipping, so let me hold it. Okay. This probe doesn't want to stick there. Either you can go like this. If you are going like this, I hope my hand is not disturbing all of you now. So if I am going like this, this becomes in plane because I will be able to see the whole shaft of my needle if I am going like this. I can do also out of plane means I can inject either from this side, from the middle of my probe, and I can just inject from this side, from the middle of my probe. So that becomes out of plane, but these two are in the longitudinal axis to the Achilles tendon. What else I can do? I don't want to go for this long axis. I don't like it. Okay. Now, what you can do? Now, this was the Achilles tendon. What is this? This is my probe. Now the probe is in the short axis. Short axis. I'm looking at the Achilles tendon in the short axis. Now, if I am going like this, okay, again my hand is. Wait, just give me a second. So if I am going like this is the probe, and I'm going from here. Okay, let me show you. Just imagine this is the that side I'm showing you. So if I'm going like this, so that is the short axis in plane, and this is the short axis out of plane. So anything you can approach in the gist of the story or the take-home messages, anything you can just approach either in the long axis, you can approach it in the short axis. It depends on you, how comfortable you are in doing that. Until unless you are causing any harm to the patient, any axis, longitudinal, short axis, out of plane, in plane is good. But as a beginner, I would always suggest you to go for in plane in your initial days. And once you are well versed with the needling, you go for out of plane, whatsoever you feel like. Fine. And it is always better because you are able to see the shaft of the needle fully and you know exactly where you are going. So this is applicable for anything you are going for needling. So this is why I have shown you that you can do in whichsoever position you feel like. So any questions now you want to ask me?
Ma'am, in all the positions, the probe will be towards the talus or only in the short axis that you told that the probe direction is?
For ATFL?
Yes, ma'am.
ATFL, it should always be in the short axis because see how it is. You have your fibula here and then you have your talus here. So this ligament is something like this. So your probe needs to be in the short axis. In the long axis, if you're putting, you will be able to see a cross-sectional portion of that ligament. And if you're able to see only a cross-sectional portion, you will not be able to make out any tear or pathology of the tendon fully because that ligament fully, because you need to evaluate that ligament fully from where it is originating and where it is inserting. That's why it should always be in the short axis. The probe is in the short axis, but we are looking at the ligament in the long axis. But the whole ligament we are looking, na? We are not looking at cross-sectional portion. So the ligament is in the longitudinal, ligament is like this, and your probe is also exactly, I should say, longitudinal axis to the ligament, but if I'm holding, that is the short axis.
Right, ma'am, right.
Okay, because I've started with fibula. So that becomes a short axis for the fibula. Fibula is like this. So I am holding my probe like this. So my probe was perpendicular to fibula. That's why I said it is in short axis to fibula.
I think I missed this thing that in the last you told all the access, so that was not for ATFL.
See, ATFL, see, if I'll tell you why, where you are getting confused. See, if it's you want to go for an intervention. Intervention you can do in out of plane or you can do in plane. But when you are evaluating a structure, see, there is a difference between doing a diagnostic scan and there is a difference between doing a therapeutic scan. Diagnostic means you are just trying to evaluate the pathology. So you have to be very particular, where is that structure located, how should be the position of your probe. But when you are doing an intervention, you know there is a pathology in this, so I have to do an intervention in this. So if you are very much well versed with out of plane technique, you can go for that. If you are not comfortable, go for an in plane. Even with the out of plane, you can just do the tenotomy, you can do the needling of this ligament, and then you should inject. Because when we are doing the needling of the ligaments, we are just causing the artificial inflammation there. And when we are giving the PRP, so that will be like, double cheese pizza. Understood? Means you will be just now, already the inflammatory mediators will come and you are now helping also. So that ligament will heal very fast.
Thank you, ma'am.
Scanning area for ankle sprain. So you can just go through my ligaments, YouTube video, everything is there. All the things I have done live demo. So right now it's because already 8:10. So
yes, what you can do is you can later on in this group, you can see, give the link of the YouTube video.
I've already shared, sir.
Okay, then it is there.
Okay, that's all from my side. Any more questions?
Madam, needle endpoint for PRP injection for plantar fascia.
Needle endpoint
For PRP injection.
for PRP. Okay, I will tell you one thing which you should learn. Sir, can I just answer her questions and then you
yes,
can...
you can hold your probe on the screen with your, the...
Yeah, that's what I'm doing.
So what the needle should be, in which direction it will be going.
Yes, that's what I'm doing. Oh, so let me increase the gain first.
We can't see the screen.
Oh, oh, sorry, I have not changed it to obvious. Okay, just 1 second, please. Hopefully now you are able to see.
Yes.
Okay. Let me show you. Now you see, all of you, this is not only for who has asked me the question, this is for everyone. Imagine this is my needle. I am going to bring it. So that is the first. I will be coming and I will be just, okay. Now before that, okay, now I cannot move the probe. Okay, I'll do one thing. First, understand this. Oh God, it's gone. I pressed the in to come out. No worries, I'll be showing you again. Don't worry. Now, first understand with the arrow. This is my plantar fascia. This is the upper portion. This is the below portion. So if I want to inject my plantar fascia, my needle should be within this territory. I should not be going out of this territory. So if you want to bring, how are we bringing? Now you see, this is my needle, which is coming from there. I will be going. Now I will be stopping here inside the substance of my plantar fascia. And if you are injecting PRP, I would just say do the needling of this fascia and then you inject your PRP. So it should always be within the territory of that structure which you are gonna inject, whether you want to go for a PRP, you want to go for a dextrose, but at the same time, if you want to go for a, no, I need to come out, only then, again I have to show because measurement I have to come out and then only I can show you. So give me some time so that I can. But if you want to give steroid, you are not going to go inside the substance of the fascia. You will be injecting on the top of this fascia. Make sure you are not injecting in this structure any steroid, because if you will be injecting here in this fat pad, so this will be going for an atrophy. So do not inject in this, just inject above this fascia on the top. And the same holds for tendon. If you are injecting into a tendon, it local with steroid, because you don't have an SS to PRP. So you are injecting local with steroid to relieve the patient's pain. So that time inject it on the top of the tendon. You are injecting PRP, you are injecting dextrose, you can inject within the substance of that particular, whether it is ligament, whether it is tendon. So this holds true for all the tendons and all the ligaments. Understood?
Thank you, madam.
Any more questions?
We just inject straight away or give anesthetic first, then inject?
It's always better to give a nerve block rather than using the local anesthetic, because if you are just using on the skin, then it is fine, but do not inject the local just near the fascia, because what will happen local, if you are injecting, you will be changing the acidity. So pH we should not change. So to the skin, yes, you can just inject the local, but when you are using ultrasound, if you have an SS to ultrasound, please do everything, even a bit of local infiltration also, you do it with ultrasound. So what you can do, I'm just showing you here. Okay, I need to show you the screen once again. So let me show you the screen. So when you are injecting, suppose you want to inject. So this is your skin and this much is your, this much if you inject, that is fine, you know, local anesthetic, but do not go and keep on injecting till here. So you can just inject into the trajectory of your needle. Somewhere, you know, you can just start injecting local, you can just inject up to there, but do not go inside this. Because if you will, where you are putting the PRP, you should not be injecting the local, because that will be changing the pH, and we should not be changing the pH. Otherwise, that will be causing the damage to our platelets. Okay, I'm sorry that video got
Thank you.
stuck. Okay.
Thank you.
Any more questions? No questions, then we are ready for Kahoot.
Yes, start Kahoot, and then if any questions, please put it in the chat box. So even after Kahoot also, we can answer the questions.
Kahoot
So
will be from your side.
From my side?
Yes.
Who will be doing Kahoot? Devjyoti or Chinmay?
Boss, are you there?
Hello.
Yes, boss.
Yes, I am here.
You are here. Then let's have some, you know, break from the presentations.
Yes, today you had a marathon class.
Yes.
One person whole more than 2 hours.
I was running. I was trying to complete it so that, you know, everybody is
So
like.
you have covered it nicely, and now with time, and hopefully there is no more questions. But still, if there is any questions regarding what Dr. Kanchan demonstrated today, you can put it in the chat box so that after Kahoot also she can answer.
And those who want to see anything which I have shown, stay back with me. I'm ready to show you again. And those who want to go have some dinner, relax. So it's up to them.
And all this ankle, knee, it is there in our YouTube channel. Clinical
Knee is
method
not there.
also is
Knee
there.
is not there.
Knee, I'm talking about the clinical methods.
Achha.
So clinical methods of the ankle, knee, it is there, and the knee, ankle whole of this nerve, tendon, ligaments, everything is there. So please go through that and read it.
I have already shared. I hope they would have gone through it also.
Hello.
Yes, boss.
Just a minute. Last day we covered the sympathetic, na? In this batch. Actually, now 3 batches are running, so it is very difficult.
3 batches are running, so it's difficult
Last
to
day
remember.
for this batch, it was sympathetic, na?
The CRPS and
Sir, CRPS and USG guided the
Cancer pain, sir. Cancer pain.
celiac
Okay, the
plexus block and
sympathetic. Okay, I got it.
Wow,
CRPS.
everything's like so this thing. I'm so happy to hear this. All of you are reading so well. Even we have forgotten, see which class we have taken. It's good.
Okay.
Hello.
Hello.
Sir, I'm Dr. Praveen, not able to enter the pin. It's showing there is a problem with game pin.
So many people are able to join, so there is no problem with the gain pin, that's for sure. So you just you can just reconnect.
Refresh and try to put a pin again.
So I think 37. How many are there? 59. So many people have not joined. Please join. There's a huge difference. It will be only 4. That means if there are total 59 participants, there should be at least 55 participants because 4 of us are there. So please join. Those who are not joining, please join. Anyone is having problem or they don't want to join?
Okay, Devjyoti, you start. If
Okay,
anyone
let's
has
start.
any problem, they can
Yes,
put it in the chat box. They can write in the chat box.
Because this number difference is huge, 59 and 38. So either they have opened the computer and gone for some other work. Okay. So 16 plays like that. Let's start. So game pin, even if you start late, game pin will be at the left lower corner, right lower corner. Let's start. The superior hypogastric plexus is located in front of which lumbar vertebra?
Devjyoti, probably this count has been taken for this batch.
Cannot remember. This count is taken?
Yes, sir. This has been taken.
Sir.
yes, sir. This question was
Yes, sir.
previous
Last time I
before
guess
taken.
for sympathetic blocks it was taken.
But I think we have only this one because last time when we prepared, both the classes are together. So I think both the questions here, questions are together here. Because see,
Boss, you go to module 9. Module 9. Today was a module 10th, right?
Yes,
So
but
go to module 9 questions.
Last time we had CRPS, sir.
Sir, CRPS and cancer pain.
Okay, just a minute.
US and US.
Okay, but how to end this game? There is no way. Okay, let me stop and reconnect completely. Otherwise, no way, na? We have to leave and reconnect. Kanchan?
You close it, boss.
Okay. Okay. Actually, there are two questions here. Last one was USG guided, right?
Boss, you go to module
Yes,
9.
sir.
Module 9 is
Yes,
there.
sir.
Yes, sir.
Okay. But the first
Ultrasound
question,
guided.
actually, the problem occurred because first question is same in both this.
Okay.
Okay. That's why
Yeah. Maybe.
the question.
Boss,
The problem.
boss wanted to test whether, still wrong or right. But still see everybody recognize it. So that's a very good sign that they are very attentive.
Okay, the first question is same. The second question, let me check once again. So, no, Kanchan, we have, I think, only this one. Because within this basic module folder, we have this one, and within miscellaneous folder, we have the same present, same account.
Even with module 9?
Yes, there is no such thing as module 9. We have only this one and
Okay. Then
okay.
there won't be any Kahoot today.
No, there won't be any Kahoot today, I think, because it is already done. And in
We
both the modules,
apologize.
because I think last
for the
time we have
mistake
not
from my
taken
side.
USG and this thing separately. We have taken a combined one.
Can we have the Kahoot for this next time, because we'll need to know some important questions for CRPS and all.
Okay, no problem.
Okay, no problem.
We can have it. Not a big issue.
Because I think in last course they were combined in single class.
So no, CRPS and cancer pain. So
Yes,
few
yes,
questions
yes.
will be there from cancer pain and CRPS.
Okay, fine. Yeah.
Okay, thank
Because
you,
last time the sympathetic one was combined with the CR one that was on the same day. So here in the Kahoot, it is in the same Kahoot.
So it will be knee, ankle. So a little bit more questions than 10 questions. Knee, ankle, and
We'll ask 20 questions, sir. 20 questions we will ask.
20 will
yes,
be too much. I think 15 will be enough.
Cancer pain, CRPS, ankle, knee. These four. Okay, so let us end today's sessions, because in the chat box I can't see any more questions regarding today's classes. So if there is anything regarding today's class, it's fine. Okay,
Sir,
I can't see anything.
I want to ask one question. Sir, it is possible, can you again show please S1 transforaminal?
S1 transforaminal. Okay.
Yeah, sir.
When we'll be having the CR module, that time we will be demonstrating.
Okay, sir. Okay, thank you, sir.
Okay, then good night, and we apologize for today's, problem from
no
our
problem.
side. So just forget it. Okay, so we'll have next time, and that's all from my side. Good night. Take care. Study.
Yes. Good night.
Thank you, ma'am. Thank you, sir.
Good night,
Good
ma'am.
night, sir. Thank you.
Good night, sir.
Good night, sir. Good
Thank you,
night,
sir.
ma'am.
Thank you,
Good night,
ma'am.
sir.